as you will see, as you can see from the session, there will be surgical management, there will be radiotherapy role and advances in radiotherapy, and then neoadjuvant therapy and its role, and also the adjuvant therapy. So we will be covering the main modality of managing of lung cancer. And that's why I will only focus on the advances in the surgical technique. To start, we know that management of lung cancer remains a challenge. Despite recent advances on the things that we've mentioned, that we talked about target therapy, immune therapy, advances in radiotherapy that had a positive impact on the management of all stages really of non-small cell lung cancer, surgery remain the best treatment modality, and the highest rate of curative resection can be achieved, aided of course by other modalities. Although we see more of advanced non-small cell lung cancer in general, but I believe that when we talk now about non-small cell lung cancer, and when you talk about early, there is a big sector of, I would say, more advanced lung cancer that should be treated with intention to cure. So do we see more cases of this early stage lung cancer? I think we are started to see more cases than I used to see maybe 20, 30 years ago, probably because of screening that have started in some places at King Faisal Specialist Hospital and other patient awareness of the importance of screening and awareness of new symptoms that require diagnosis. And also we have better diagnostic tool. The era of PET scan really have changed a lot, management of malignancy in general, but in non-small cell lung cancer in particular. So we have now better staging to these cases, and we can actually differentiate easily between early and advanced lung cancer. We also are better in assessing our patients and supporting those patients to be suitable for treatment. So we are now more accurate in assessing the cardiopulmonary status, and we can actually do rehabilitation, improve the patient health, and make them more suitable for all treatment modality, whether it is surgical or non-surgical. Also staging, before we used to see advanced stages as a case not for curative intention, but now we are having sub-classification of even M stage, where in selected patient surgery may still play a role. Definitely the support of advanced radiotherapy or neoadjuvant therapy have managed to bring what we call advanced or locally advanced lung cancer into a resectable and early stage lung cancer. So downstaging really plays a role. And when you talk about early non-small cell lung cancer, you should also include locally advanced that had responded to neoadjuvant therapy or added treatment modality. And definitely in general, the outcome is better when we have target and immune therapy, and this will be discussed in the coming talks. Now, in general, what is our principle as surgeons in managing the non-small cell lung cancer early or locally advanced? Number one, and we emphasize that to all audience who are listening, is that every single case of lung cancer should be discussed in a tumor board setting, and a collective decision and consensus should be made. Even if you feel that this is early stage and the treatment is surgery, no other modality is needed, no, please bring every case to the tumor board and make a decision. There will be a pathologist who can highlight a lot of issues regarding markers and mutation. There will be a radiologist who may detect areas of suspicious of metastasis or advances that is not known. There will be a supportive colleagues from other oncology related topics. You will be needing counselor, you will be needing patient support, and a lot of really input. And this definitely have proven to improve the outcome. And we always, as surgeons, ask ourselves whenever we are approaching a patient, really, especially when I teach residents and fellows in the OR, once we are approaching a patient, we ask, do we have a diagnosis? And occasionally, you may be operating on a patient with high suspicious malignancy or suspicious primary versus secondary, and a definitive diagnosis needed to be made. So please make sure before resection that you have a definitive diagnosis. If you have in doubt, even intraoperatively, use the frozen section and pathology. There is no harm to delay your surgery if you see unexpected thing until you confirm your diagnosis. Second question, do I have the right staging? And a lot of times as surgeon, we open the case as an early stage lung cancer, but we find otherwise because radiology remain not 100% accurate in staging. So before you do any surgical procedure, do a second assessment. Do you have a pleural effusion, any evidence of pleural nodules, any other nodules in the other lung? Explore the mediastinal lymph node, any suspicious, and you always have a tool to, and we now do that by thoracoscope. So it's a minimally invasive opening to assess before we proceed with resection. So make sure you have the right staging. And number 3, do we have a good pathological and molecular testing, not just pathological testing, that we are going to do that. Again, whenever the role of neoadjuvant therapy in recent years have changed. Cases that we thought it's early and will not benefit from neoadjuvant therapy, now there is a trend, and you will be hearing these studies in the coming lectures, that neoadjuvant therapy may actually improve resectability or improve the outcome, and no need to proceed directly with surgery followed by chemotherapy. Always ask yourself before you go for surgical treatment that this is with curative intention, and can I do a curative resection? And you have more time to assess patient during surgery if he's fit for the procedure. We have techniques with the anesthetist to evaluate borderline cases, whether a lobectomy can be tolerated, or especially pneumonectomy, whether it is tolerated or not. So make sure you do that. And post-op, again, this case should be rediscussed in the tumor board and see if any post-operative treatment modality would be of help, whether that was planned pre-op or based on finding and histopathology. Now, that's why when I really started to shy away from the word surgery for early stage lung cancer, because we still do surgery for patients with metastasis, the most advanced stage, especially M1A and M1B. So in general, the tradition is that stages 1A, 1B, or TA and TB are really surgical, and the 2B in particular may benefit from neoadjuvant therapy, as we will be hearing. But I would consider selected cases in stage 3A, whether are N2 or non-N2 diseases, that they are also suitable for surgical resection. And whenever we treat a patient who is not surgically resected because it's locally advanced like T4 or associated N2 and N3, we should reassess the patient with whenever other modality to see if this patient became a surgical candidate and offer a higher chance of cure. And this also we do with metastasis, whether this is solitary mets, 1A or 1B. Another important issue is during follow-up. Sometimes you see a case which is early stage lung cancer and offer surgery, and then during follow-up, this patient developed metastasis, intrapulmonary or extrapulmonary, and this still could be a candidate for metastatectomy, despite we know that this is stage 4 disease, and even 4A and sometimes even 4B, but we don't give up. As long as we have intention to cure. What have we changed? I would say 40 years ago and today, and see what have changed. The main things, I think oncological guidelines of surgery did not change. Really, you have to follow the oncology guidelines for surgeons. Minimize manipulation, avoid spilling veins before arteries, make sure your margins are free, use the frozen section. All these guides were very important towards a better surgical outcome. But what has changed is now we are moving from classical surgery to what we call minimally invasive surgery. And minimally invasive are usually two types, either video-assisted thoracoscopic surgery or robotic surgery. And we have experience with both. Minimally invasive or thoracoscopic is either single port surgery or multiple. This is a picture where you can see the multiple port along VATS, but also you may, we are doing this more frequent now, which we call the single port minimally invasive surgery, where we have a 3 to 4 centimeter opening without rib spreading, and we can operate through that hole and put a chest tube. And by this, you can do even pneumonectomies without utility incision. So we have changed our surgical approach, but we did not change our surgical principle in dealing with this. This is obviously have a lot of benefits, mainly in post-operative recovery, reduce post-operative pain, reduce hospital stay, and have a better outcome. But the question was, did we actually have a better survival? And now, as I'm saying, I will come to this. Another thing we used is the era of staplers, really managed to have better control and better outcome using vascular staplers, not just to the lung tissue, but also to the vessels and the bronchus. It reduced the incidence of bleeding, reduced the incidence of bronchopleural fistula, reduced the incidence of post-operative air leak, and improved the peri-operative period. We wanted to take that longer and say, did that actually affected the outcome of a routine thoracotomy, doing a lobectomy for stage 1 versus minimally invasive? And collectively, we have seen a trend, I would say, toward improved 5-year survival. And there have been a lot of theory about why minimally invasive is better and can produce survival. One of them is the effect of surgery itself on tumors and the manipulation and handling, but also the reduced post-operative morbidity and mortality due to minimally invasive access to the surgery. So there is now a good trend that if this case can be done by minimally invasive, it's favorable, not just for the pain and hospital stay, but may even be for the long-term survival of the patient. So now we are using this as a standard access to our lung cancer cases, especially early stages, who are suitable for robotic or thoracoscopic procedure. Another issue that is advanced, there was a professor called Ginsberg who wrote an important paper around 35 years ago that any surgery less than a lobectomy does not actually give you the same 5-year survival. This has been challenged in the presence of post-operative radiotherapy and target therapy and post-operative target and immune therapy. So really, we are now playing more role when it comes to segmental anatomical resection, especially for those patients who are with poor performance. We are also surgically have better technique to reserve lung tissue when there is a big tumor by utilizing what we call sleeve lung resection, and where we can actually resect a lobe, middle lobe that is, before we would have done a bilobectomy, but do just the middle lobe and re-implant the lower lobe again. We do that also for avoiding pneumonectomy. Upper lobe tumors that involve the main right main bronchus and left main bronchus now can be resected with sleeve resection and reimplantation of the remaining lung again. And this really helped us in doing curative, safe surgery, but tolerated by the patient, and hence we are improving the results. Even wedge resection for high-risk patients combined with radiotherapy are now showing very promising results. And I didn't go into that because you will be hearing this in the next topic. The point also I want to add is, when I say advances in surgical approach, is the cases which we call locally advanced. Even with locally advanced, we are now encouraged with surgery, whether with preoperative neoadjuvant therapy or radiotherapy and not. We can do in-block resections. We handle Bankos tumors. We can handle major structures invasion with really curative intention and good results, like tracheal invasion, cranial resection, or combined resection with vertebra or diaphragm or other organs. Of course, this is selected patients. They are not there when you see the results of, let us say, T4 tumors. You will see the curve quite low and not suitable for surgery. But in selected patients, really, you can, and the advanced technology that we have in surgical technique and post-operative care, we can do that. I'm just giving you a recent case that we've done. A patient, it's Bankos, but also was involving the vertebra. This patient had preoperative chemoradiotherapy followed by surgery. We had the neurosurgeon with us, and we did hemivertebrectomy and actually had to fix the spine. But eventually, we managed to provide a curative surgery and make this a surgical candidate with high prolonged survival after that. Even with metastasis, as I said before, especially pulmonary ipsilateral or solitary brain or adrenal, especially if they also in the ipsilateral side, really we have a good records of cure in those patients, whether this was a synchronous tumor or occurred during follow-up. My personal experience with bone is not good, so I'll leave that for the radiotherapy. Maybe they can handle that better than surgery. So in general, when you talk about management of surgery, surgical management, it's not only the surgery, but also the perioperative period, the anesthesia, the post-operative care, the ICU care, rehabilitation, and close follow-up with recent imaging like CT scan and PET scan, MRI, based on the indication. So the advances in surgery, not just related to what the surgeon does, but also with all the supportive therapy that improve the outcome of surgery, and that the surgeon is not alone into this. He's part of a team, and everybody will play his role into advances. So in general, I would say, again, emphasize that the presence of tumor board, presence of multidisciplinary team have led to a better decision, even for us as surgeons, in managing patients with non-small cell lung cancer, and whether they are early stage or locally advanced. The new modality of surgical management, from approach to minimally invasive, really have proven day after day that it improves the surgical outcome. And the support of neoadjuvant therapy, whether it's in the form of chemo or radiotherapy, made some of the what we call locally advanced surgery converted to downstage to early stage and can benefit from surgery. Thanks to radiotherapy, we can now do even sublobar or wedges resection with good results in patients who cannot tolerate a bigger surgery. At the end, better selection of our patients and better patient care will always have an input in the outcome of surgical approach in managing resectable non-small cell lung cancer. Thank you.
Thank you so much, Prof. Alkattan. It was a wonderful talk. We will leave the question at the end of the session. Now we will to Henry Barr. He's assistant professor of radiation oncology at Yale School of Medicine. He will talk today about the role of stereotactic ablative body radiotherapy in early resectable non-small cell lung cancer.
Thank you very much. Give me one moment, please, to try to share my screen.
Please share your screen and start.
Okay, are you able to hear me?
Yeah.
Okay, excellent. Thank you very much for the invitation to speak today. I'm very honored to be here. Today, I'll be speaking about the role of stereotactic radiotherapy in operable early stage non-small cell lung cancer. So thank you for an excellent talk earlier about surgery as well. I'm here to talk about another option called SBRT, or stereotactic body radiation therapy. It's also known as stereotactic ablative radiotherapy as well, which some people call SABR. Here I'll be talking about I'll be using the acronym SBRT here. So first, I'll go over a little bit about the overall evidence for SBRT in inoperable patients, for those who are not able to undergo surgery, but then some of the more controversial areas these days regarding SBRT for patients who could potentially undergo operation. And then we'll discuss a little bit about a new study regarding SBRT plus surgery for operable patients, and then some ongoing trials of SBRT versus surgery. We'll also discuss our approach at Yale in how we decide between SBRT and surgery for those who could undergo either approach. So this trial came out last year. It was from the TROG group. It's called CHISEL. This showed that SBRT, which is a high radiation dose delivered precisely to a small target over a few number of fractions, that this was superior in local control and overall survival compared to conventionally fractionated radiation, which was often given in about 30 treatments, 5 days per week, over 6 weeks. So that is one area here when they treated usually about 3 or 4 fractions of a very high dose that they could show an overall survival improvement. This is something that we basically knew already to some degree. This was really the overall practice has changed throughout the world overall in this area, but this was really the first proof that in a phase 3 study that this was the case. So this was all based on the RTOG 0236 trial, which was published back in 2010 originally, which showed 3 fraction SBRT using a high dose. The primary tumor control was 98% at 3 years and 90% at 5 years. If you're comparing it to surgery, though, the key metric here is involved lobar control as well, especially if you compare it to lobectomy. So here we see that at 3 years, the local control was 93%, and it was about 80% at 5 years. So there were recurrences, that happened beyond the 3-year mark, which we certainly see in practice as well. And the long-term results were published back in 2018. So for more central tumors, if the tumors are a little bit closer to the tracheobronchial tree or the proximal airways, then we often use 5-fraction SBRT to a lower dose each day, but spread it out over a few more sessions. And we found on the RTOG 0813 trial that this was an overall good regimen that was safe and effective. Where we have to be a little more cautious, though, are those that are considered ultra-central. So these are the central tumors are defined as within 2 centimeters of the proximal tracheobronchial tree, whereas these ultra-central tumors are more likely to be abutting the trachea or main bronchi, especially the ones that are most concerning. This trial here showed that there was a high fatal toxicity here, about 30%. Here for those that were immediately abutting the trachea and main bronchi, much less so for those that were abutting the lobar bronchi instead. So, SBRT patients have, so here the question is, are we able to look back at any observational data to detect any differences between operable and inoperable patients? Because we know that patients who are selected for surgery may be different than those who are selected for SBRT. And those who actually receive SBRT may be more likely to not be able to receive surgery. This is one study out of Yale that showed that when we look back in those who were either medically operable or inoperable, that those who were operable did have higher overall survival. But that the risk of local failure and the risk of regional and distant failure were the same either way, showing that this is not necessarily the reason for there not being operable may not be necessarily having to do with tumor characteristics, but more having to do with patient characteristics in terms of the comorbidities or other life expectancy metrics that would render someone to be not a good surgical candidate. This was also shown here in this study that just came out, I believe, last month from City of Hope in the US that showed that SBRT patients do have higher overall survival when they're medically operable than when they're inoperable. But otherwise, very similar local, nodal, and distant patterns of failure. This trial here was specifically looking at outcomes of patients who were operable, and then also a separate cohort of those who were inoperable in a clinical trial format, and showed very similar results here as well. So in terms of surgery versus SBRT now in patients, is there any way in the US to really, or using observational data to really determine whether or not one is superior than the other? Overall, the studies that have looked at this have essentially uniformly found that surgery is superior to SBRT in overall survival, or at least those who received surgery had higher overall survival than those who received SBRT. We know that selection bias could be significant despite extensive adjustments for known confounders. This is one trial here that, this is one study from the National Cancer Database in the US. That showed a very striking difference in overall survival, but unfortunately, without any metrics on overall survival, on cancer-specific survival, on local control, and also on side effects, it was very difficult to detect if there was a difference there either. We also know that SBRT patients are more likely to be medically inoperable from other medical conditions, poor performance status, or poor PFTs, and also they may be understaged without a mediastinal lymph node dissection, which is one issue with SBRT as well. Excuse me. So now, do we have any trials on this subject of SBRT versus surgery? There have been multiple trials that have been open on this topic. We have some that are still accruing, but unfortunately, most of them have closed very early due to poor accrual to these studies. But this is one effort here, the STARS Roselle trial. Well, really, this is a collection of 2 underpowered trials that were pooled together. That because they both closed early from poor accrual. And they showed here that SBRT was no worse than surgery. The actual outcomes were actually a little bit better for SBRT in this case, but again, a very small study, and I don't think anyone would argue that SBRT is necessarily superior to surgery for operable patients. But at least the signal here suggested that there wasn't a detriment in overall survival here among patients who were good enough candidates to be randomized to either surgery or SBRT. Recurrence-free survival also was very similar between these two arms. But you see the numbers at risk overall, a very small collection of patients, only 31 in this SBRT study patients, and then 27 among surgery. Here, let's see, this is called, so this was presented at ASCO this past year. Here, so this was presented over at ASCO in 2021. This is from Joe Chang at MD Anderson, who expanded the STARS protocol to a single-arm SBRT trial with protocol-specified comparison to a longitudinally followed institutional cohort at MD Anderson of stage 1A non-small cell lung cancer. So who underwent VATS and lymph node, lymph node dissection as well. So overall here, they've added about 80 patients to this trial, or at least to this cohort, and found very similar results in terms of overall survival and lung cancer specific survival. Here we see that SBRT is no longer superior, which is expected. But that overall is very similar in really all the metrics they've looked at, including progression-free survival, lung cancer specific survival, and local, regional, and distant recurrence. So these slides are courtesy of Joe Chang, but very interesting data, and we'll be keep an eye out for this in Lancet Oncology, where this paper has been accepted now and not yet published. So one other possibility, especially during the COVID pandemic, was which I think was intriguing to a lot of people, was the idea of SBRT and surgery for operable patients. We don't know if this is a superior approach or not, but this was explored over in Ontario, Canada, with a group over there. So they found 0% perioperative mortality, 2-year local control of 100%. Overall survival was 77%. Pathologic complete response was 60%. The criticism of this is that this is only 10 weeks after SBRT. And we know that the biology of SBRT is that that the radiation continues to exert its effects on the tumor in terms of viable cells afterwards, long after that 10-week mark. But we know that this approach seems to have worked quite well, at least in this cohort here of about 40 patients. This is something that could be further explored and has garnered some interest during the time when elective surgical procedures were being canceled, at least in the U.S. Over the COVID pandemic, and some patients who were operable may be candidates for being bridged with SBRT followed by surgery. Although not clear if this is a better approach than either surgery alone or SBRT alone. So ongoing trials here for SBRT versus surgery. These include the VALOR study. So this is run through the Veterans Affairs in the US right now. This is a phase 3 study that compares SBRT versus lobectomy or segmentectomy in stage 1 non-small cell lung cancer. There's a stablemates. So the VALOR study is accruing quite well based on what I've heard. Over 100 patients already accrued, which is much better than any other trial so far has that's been published. I don't think anything else has ever gotten anywhere close to the triple digits like that. But they're aiming for over 600 patients overall. So we're hoping that this will be the really main study that we'll look at several years from now to help answer this question. The stablemates trial is from the Joint Lung Cancer Trialists Coalition. This is looking at phase 3. This is another phase 3 study in the US looking at SBRT versus sublobar resection in non-small cell lung cancer. And I know this was brought up a bit earlier in the prior talk, but sublobar resection may be, there's new evidence for supporting sublobar resections for certain patients as well, potentially. So this is another study that would look at that question. There's this other study out of China here called POST-LIV. It's called POST-LIV. So radical resection versus ablative stereotactic radiotherapy, and those are operable stage 1 non-small cell lung cancer. So it's a phase 2R study with SBRT versus radical resection for T1 tumors specifically that are peripheral. The other, one other angle here that could be interesting is SBRT with immune therapy. And I know there's going to be talks going forward about immunotherapy and its role in locally advanced metastatic settings. But in the early stage setting, there's a lot of interest in combining this with SBRT as well as with surgery. I think there's an interesting study recently with the Empower 010 study showing disease-free survival benefit to adjuvant atezolizumab after surgery. This is intriguing. If SBRT and immunotherapy, which there's some biologic reasons why we think that they may be synergistic with each other and really help each other's effects quite a bit, then if that's the case, then could this sway us a little more towards SBRT in certain operable patients as well? I know we have a couple of these trials open here at Yale where we see that patients who may be borderline for surgery, that having these trials available, whereas SBRT plus immunotherapy may be appealing to certain patients. So the Keynote 867 study is SBRT with concurrent and adjuvant pembrolizumab versus placebo for 1 year every 3 weeks. So this is a study we have open currently. But then with other immunotherapies as well, there's a Pacific 4 study with R2G, also known as R2G Foundation 3515. This is SBRT with adjuvant durvalumab for 2 years versus placebo. In this case, the durvalumab is given after the SBRT is finished, as opposed to the pembrolizumab in the Keynote trial is given with the first day of SBRT and onwards. The SWOG study, S1914, is a little bit different in that they actually start priming with immunotherapy before SBRT, 2 months beforehand. So we get 2 months before SBRT and then 4 months afterwards. So this is the shortest duration of immunotherapy of all these studies, and also looks at the idea of neoadjuvant therapy as well. So this could be an interesting arena as well to look forward to in the future. So here, what's our approach generally? This is some work that our group has put together and that's been in submission now. These figures here are a little bit busy, but the basic idea is we try to determine, which patients we're talking about here. So among older patients who may be operable, how do we decide between surgery, also radiofrequency ablation or other ablative procedures, and surgery. And we took a look back at all the papers that have come out in this area, which there are many that I didn't have time for today. This could be an hour-long talk easily on all the papers that have come out. But here we try to summarize what the papers have generally shown, despite, of course, the key selection biases that affect most of them, because most of them are retrospective. We divide this out in terms of short-term, intermediate term, and long-term outcomes. So we know that SBRT, we're quite certain at this point that SBRT compared to surgery does have likely superior short-term outcomes in terms of complications. There's a much lower risk of death in the short-term period in the first 3 months after surgery, after SBRT, compared to surgery. Quality of life and pain seem to be better in that time period as well. However, as the years pass, the differences definitely may change. In intermediate outcomes at 1 to 2 years seem to be quite similar overall between SBRT and surgery. And then for longer term outcomes, the overall survival and lung cancer specific survival have been shown to be those who received SBRT have not lived as long, without cancer and overall compared to those with surgery. But again, those issues that we discussed before in terms of who is selected for each really play a large part here. So how do we, determine this, or how do we use this to help us in clinic? Is that we really determine patients' preferences in terms of how outcomes are weighed. Here I've one on older and one on compromised, but they're fairly similar, concepts here, which are you account for age, you account for frailty, overall compromised medical condition overall, in terms of, the fact that these things can accentuate these short-term differences, which may be of great interest to these patients is how they do in the next several months and maybe a year or two, but not necessarily 5 years from now. We know that aggressive tumors can also accentuate these long-term differences as well. And so major selection factors include, patient robustness to get through that 90-day period after surgery. What is their performance status? What's their pulmonary status going to be? What are they looking for in terms of, their pulmonary function afterwards, in terms of functioning the way that they want to function. There's also, of course, tumor and technical factors influencing treatment differences regarding what kind of surgery is involved. Also, what dose of SBRT we're able to safely get in, and also tumor aggressiveness. Really, the impact of long-term outcome differences really has to be weighed as well, as compared to the short-term differences. So this is one way of thinking of it. There's many ways of determining an overall approach to which approach may be the preferred one for each individual patient. But these are all factors that we weigh out regarding the benefits and downsides, as well as long-term outcomes and short-term outcomes that are determined by patient values and preferences. And that's all I have today, so I'd be happy to take any questions later on.
Thank you so much. It's a nice topic, but I'm expecting a hot discussion at the end, inshallah. Thank you so much.
Assalamu alaikum. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.
Thank you very much, Dr. Ashwaq and Dr. Khaled for introducing the session. Thanks to the speakers for delivering really excellent talks. Moving on from two important modalities, surgery and radiotherapy, to equally important modality, which is systemic therapy. And we have two speakers. First, I would like to introduce my friend and colleague, Dr. Ahmed Alleheibi. He is a consultant medical oncologist at King Faisal Specialist Hospital in Jeddah. He is interested primarily in lung cancer and also treats GI malignancies. He will be talking to us about the role of neoadjuvant systemic therapies before surgery in patients with localized lung cancer. So we'll all enjoy his talk.
Assalamu alaikum wa rahmatullah. First of all, I'd like to thank the organizing committee and the scientific committee headed by Dr. Ashwaq and Professor Khaled as well for inviting me actually to this educational activity and to this meeting. And I'm not going to forget about Dr. Samah Alrehaily, who's co-hosting the moderation as well. So the task that was given for this meeting is going to be about neoadjuvant options for localized non-small cell lung cancer. As we all know, there hasn't been a lot of trials that has been concrete in defining the optimum or the optimal neoadjuvant therapy in terms of chemotherapeutic options for the specific type of disease or stage, localized stage, if I can say that. So without any further ado, the main objectives of this study or this presentation is going to be to recognize the role of neoadjuvant therapy in the treatment of localized non-small cell lung cancer, to identify the role of concurrent chemoradiation therapy in the neoadjuvant setting, as well as to establish the role of IO in the neoadjuvant setting, and to inquire if there is any role of TKIs in the neoadjuvant setting as well. So the main outlines of the presentation, we're going to be going ahead systemically, first by the identification of systemic chemotherapeutic and options in the neoadjuvant setting, followed by concurrent chemorad, then IO, then TKI. So I went through a lot of trials and studies, and I picked up the most important ones, mainly the first one we're going to be talking about, which is the survival benefit of neoadjuvant chemotherapy in non-small cell lung cancer, which has been, there's an updated meta-analysis of the notorious Verdetta et al. Trial, which has been published back in 2008, if I'm not mistaken. And there's an updated analysis dating up to 2010. So in this meta-analysis, they were able to enroll a lot of studies, as you can see there, more about 247 studies, and they had put in strict criteria of what are the studies to be enrolled. And they had to be RCT or phase 3 studies. They enrolled both English or Chinese published articles, and they investigated with the most important primary endpoints being overall survival. So they were able to enroll 13 RCTs, and the main schema of these trials were either neoadjuvant chemotherapy, which is the experimental arm followed by surgery, or surgery followed by adjuvant chemotherapy, which is the standard of care. So these are the main characteristics of the patient's population in all trials. As you can see there, most of the patients were falling in the stage 3 setting, as Professor Alkattan had mentioned in his brilliant presentation at the beginning of the conference. The only problem with these characteristics is that there is no one well-established chemotherapeutic regimen for which you would actually prescribe these patients, whether they have been in an early stage or a stage 3. So, as we said, it's 13 studies, 6 RCTs were done in Europe, 5 were done in Asia, and 2 were done only in North America. So here's the hazard ratio for overall survival for all cohort. As you can see there, it's overall, it seems that it favors the new adjuvant chemotherapeutic approach. However, where there's a lot of caveats into that, and we'll go into it. The hazard ratio was 0.84, as you can see there. But when we dissect the studies a bit more further, you can see that the main benefit were for patients who had a stage 3 locally advanced non-small cell lung cancer, but they were operable to some extent. And this is exactly the main distinction of what Professor Alkattan had mentioned in his presentation when he said that not all N2 diseases are the same, which is very important to understand that. And hence, the purpose of a multidisciplinary team setting is very important as well to identify that as well. So the main conclusion of this study is that the combined hazard ratio of 0.84 in all cohort translated almost to a nearly 16% reduction in death in the neoadjuvant arm, with the main caveat that these are stage 3 strictly non-small cell lung cancer. And because of the small numbers of stage 1 and 2, no definitive conclusions can be made, and it would be preferable for these patients to go ahead with upfront surgery. And as we said, this meta-analysis is an updated version of the previously noted Verdetta et al. Study. So moving on to the role of concurrent chemoradiation therapy in localized non-small cell lung cancer. And there hasn't been much of studies that looked at strictly at neoadjuvant concurrent chemoradiation therapy versus neoadjuvant chemotherapy. And this is one of the important articles that I ran into, which looked at comparative effectiveness of neoadjuvant chemoradiation therapy versus chemotherapy alone, followed by surgery for patients with stage 3A, which is the main focus of the neoadjuvant approach in these patients. So again, it was the study was a retrospective study. It looked at the National Comprehensive Database, and they enrolled patients with stage 3. Again, it's an older study, 2003-2005. They use a bit of an older AJCC staging system, and they definitely excluded carcinoid small cell lung cancer. The primary endpoint was overall survival. Then the secondary endpoints basically looked at the role of any adjuvant post-operative radiation therapy. They enrolled the patients to either neoadjuvant chemo versus concurrent chemorad, followed by surgery. And the population, as you can see here, most of these patients who had adenocarcinoma, stage was the T staging was 2, and the main treatment they received was concurrent chemorad. And the main surgical option or technique was lobectomy for these patients. So the overall survival, well, as you can see there on the graph on the left-hand side, the neoadjuvant concurrent chemoradiation therapy versus chemotherapy, there's none, the end of the tails for both lines, they meet at the end. So there was not much of difference between them. And I'd like to draw your attention to the 5-year overall survival rate on the table on the right-hand side. You can see here that all the cohort had 39% overall survival rate, and when you dissect them, they are both equal to 39% between neoadjuvant concurrent chemotherapy or neoadjuvant chemotherapy. However, with the caveat, in the neoadjuvant chemotherapy, the patients who had PORT, which is postoperative radiation therapy, had a worse overall survival of 43.5% versus 38.8% at 5 years, which actually was intriguing and was quite interesting. So they've done subgroup analysis, and they looked quite closer into the reasons for that. Why is that? So here they looked at the postoperative radiation therapy with no adverse pathologic features. As you can see there, that the patients who had adjuvant radiation therapy without adverse features didn't gain much benefit as opposed to the ones who had adverse features in this graph. And the main adverse features were positive margins or positive residual lymph node. So the main conclusion of this study is that both modalities of neoadjuvant concurrent chemorad versus neoadjuvant chemotherapy resulted in similar outcomes in terms of OS benefit. This real-world data is consistent with other randomized trials, and it is intrinsic to understand that these data are applicable to patients with upfront resectable disease. So moving on now to the role of IO, which I'm going to spend most of the time on, is, as we all know, the New Star study, which looked at nivolumab, the abstract has been published back in 2020 and is still ongoing. It's a phase 2 study assessing neoadjuvant nivolumab or nivolumab plus ipilimumab in untreated resectable stages 1 to 3A non-small cell lung cancer, good performance status, randomized 1-to-1 to either nivo or nivo-epi, followed by surgery and then standard of care adjuvant therapy accordingly. The primary endpoint was major pathological response, and there are several secondary endpoints, out of which is R0, resection, overall survival, overall response rate, and relapse-free survival. Patients' characteristics were similar. Most of the patients had adenocarcinoma, as you can see there, and the neoadjuvant therapy was completed in about 96% or 90% of all population, and 100% had R0 resection rate. So I'd like to draw your attention here to the table on the lower left area of the slide, where you can see that the 0% viable tumor after resection, when you compare it for nivo versus nivo plus epi, you can see that there's significant benefit with nivo plus epi was compared to nivo alone of 38% with a significant p-value as well. So would that translate to overall survival? It is worth noting that the patient populations are quite small, so we might face some issues when we follow up with this data. So going ahead, what I think is the most important data that we have in the immunotherapy in the neoadjuvant era, which is the Checkmate 816. And the Checkmate 816 looked at newly diagnosed resectable stage 1B through 3A non-small cell lung cancer, equal performance status 0 to 1, no driver's mutation identified in these patients. And they were stratified based on stage and the PD-1 status of less than 1% or more than equal 1%, and they randomized into 3 arms. We'll be focusing mainly on the first 2 arms, which is nivo plus chemo versus chemo alone. As you can see, their primary endpoints were pathological complete response and event-free survival, and then the second endpoints, including MPR and overall survival. Baseline characteristics were quite well balanced. Most of the patients, as we said, again, it's a stage 3A disease. So the complete pathological response, when they looked at the subgroup analysis, all patients gained significant benefit when nivo plus chemo was compared to chemo alone, as you can see there. Regardless of the PD-1 status, regardless of the histology, they had significant benefit, and regardless of the staging as well. So when you look at the graphs, they outlined that based on staging of the disease. So on the left-hand side, that's the stage 1B. The rate of pathological complete response was about 40% versus 0, and then the 23% versus 3, and it was in the 23 to 24% from stage 2A to stage 3A. So pathological complete response improvement with nivo plus chemo versus chemo alone was observed regardless of the down staging that was achieved in these patients. Again, the major pathologic complete response and was quite significant when Nivo was given along with chemotherapy versus chemotherapy alone, with a difference in the intention-to population of 27.9% between both arms. And the completeness of resection as well, the patients who had received the Nivo plus chemo, it seems that they gained some significant more benefit as opposed to chemo alone. So the main conclusion by the authors is that the Checkmate 816 is the first phase 3 study to show the benefit of neoadjuvant immunotherapy along with chemo combination for resectable non-small cell lung cancer as opposed to chemo alone. And it is a potential new adjuvant option for these patients. However, we still need to await the overall survival benefit, which is still not reported yet for this trial. So we are keeping a close eye on the final analysis in the next couple of years. So moving on to atezolizumab, which is the LCMC3 study, which looked at the addition of atezolizumab neoadjuvantly in upfront resectable stage 1B to 3B non-small cell lung cancer. And the way it was done is that they enrolled patients to atezolizumab for the surgery. Then there was a 30-day post-surgical visit with a lot of imaging and blood works. And then they would go ahead with the standard of care of just either surveillance plus optional adjuvant atezolizumab or stage appropriate therapy as per investigator. The primary endpoint was MPR, which less than or equal 10% of viable tumor cells would be present. So the patient's characteristics were quite well balanced in the study, although it's not it's not a two-arm study, but it is not as well balanced. But I mean, basically, it is basically comparable to the previous studies where majority of the patients has a stage 3A disease. So the primary endpoint in terms of the major pathological response was in favor of the atezolizumab of 21% versus 7%. And as you can see that they enrolled some of the EGFR and ALK1 positives. And this study actually preceded the ADORA trial. That's why it was enrolled under the impression that atezolizumab might give some benefit for the driver's mutation population. So the exploratory endpoints, as you can see here, when the disease-free survival was looked at on the left-hand side, that's where the graph is, the p-value was not significant at 1.5 years of 79% for stage 1 to 2 and 77% for stage 3, and the overall survival benefit was not significant as well. But we need to await the final updated results for this trial. So the main conclusion is that this study provides additional clinical evidence for the ongoing placebo-controlled phase 3 Empower 030 study of atezolizumab combined with platinum-based chemotherapy. So moving on to the role of TKI, and the first TKI role in the neoadjuvant setting is the notorious NOTOCA study, which I think is going to be a very interesting study to look at, which is a phase 2 study of TKIs in the neoadjuvant study and stage 2 and 3 resectable non-small cell lung cancer with variable drivers mutation. As you can see there, they enrolled early stage disease up to 3A or 3B even, and they enrolled ALK positive, and for the ALK positive, they received alectinib. ROS1 positive, they received entrectinib as well as NTRK. BRAF positive, they received bimorafenib and cobimetinib, which is a regimen that we use in melanoma. And then RET positive, they received pralsetinib, followed by surgery. And then when surgery was done, they would go with the standard of care platinum-based chemotherapy for 4 cycles, followed by cohort-specific TKI for 2 years, then surveillance only, followed by survival up to 2 years. So it is a very interesting study, and we all are anticipating the results within the next few years to be up from this study. Then moving on to the new addition of the role of TKI in the neoadjuvant setting, which is the new ADORA study, where the preliminary results are being promised within the next year or so. So in the new ADORA, it is a phase 3 randomized double-blinded control study. They enrolled patients with non-small cell lung cancer and the early stages of stage 1B up front to 3A, and they had to have the notorious EGFR mutations, meaning the exon 19 deletion and the L858R mutation. And they were enrolled to 3 arms as to 1 to 1 to 1. based on disease stage, race, and mutational type. The first arm received osimertinib at the usual dose plus chemotherapy, and the second arm was chemotherapy alone plus placebo. The third arm was osimertinib followed by surgery. The primary endpoint would be measure pathological response, with the second endpoints being complete pathological response, event-free survival, overall survival, and disease-free survival. So it is a very interesting study, and we all are anticipating the study to be preliminary resulted in the next 2 years. So the main take-home messages from this presentation is that all cases of non-small cell lung cancer should be discussed in a multidisciplinary setting, despite the stage. Always individualize the approach to meet each patient's needs specifically. And there is a role of neoadjuvant chemo or concurrent chemo in the upfront resectable non-small cell lung cancer, mainly stage 3, and the role of IO, TKI in the neoadjuvant setting is promising, but we'll need to await more studies to clarify that. And it is very important that when deciding about a neoadjuvant approach, we must weigh pros versus cons carefully with the patient. With that, I conclude my presentation, and thank you very much for your attention.
Excellent, Dr. Alleheibi. Thank you very much for the presentation. You've covered a good range of neoadjuvant approaches using different systemic therapies. Targeted therapy has changed the management of advanced non-small cell lung cancer over the last 20 years. Became a standard to a certain group of patients who have mutations or what we call double mutations and with lung cancer. And of course, the big question is whether adjuvant targeted therapy for these patients is appropriate or beneficial. And for this reason, Dr. Abdullah, Twairgi, chairman of the Department of Oncology at King Fahd Medical City in Riyadh. This is the reason he's going to present the following presentation. So I'll invite Dr. Twairgi to deliver the presentation.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Jamal, for the introduction, and I'd like to thank the organizer for having me here physically. So today we'll speak about targeted therapy, and I think this is probably I will focus mostly on the last treatment that patients will get it. Those who have early stage will get surgery, probably radiation, and then the adjuvant systemic therapy. So this is the last part, but it's really one of the important parts in the treatment paradigm for lung cancer based on the resectable work. So as you know, the lung cancer is one of the most common cause of death, and this is worldwide, and it's really the number are quite dismal when you look at the outcome of those patients. Even if you pick up the disease at much earlier stage of disease, you can see those patients, the stage 1 kind of 70%, stage 2 around 50%, stage 3 20, 30, and stage 4 less than 10%. Though the figures for stage 3 and 4 has remarkably improved over the last 5 years with introduction of immunotherapy as well as target therapy for the oncogenic driven tumors, and I think we are working quite well for systematic disease control, but things are a little bit lagging when it comes to earlier stage disease, because we are not really doing pretty well in the systematic disease control, and most of those patients, when they relapse, the relapse is more kind of distant rather than local disease. So as we know that the standard of care for the resectable disease is to have surgery, and this has been addressed quite well by the Prof, and to know whether they are resectable, you need to have those patients need to be discussed in the MDT meeting, and to know whether they are resectable, and putting all these figures, the staging, clinical, and so on. And once they are resectable, then the surgery is the way to go. After the surgery, based on different anatomical staging, right now we are using probably the TNM, the tumor size, the nodal involvement are probably the most important predictor for deciding whether those patients they will get an adjuvant therapy or not. Those with a bigger tumor, those with nodal involvement, usually are the one who's getting the treatment. The adjuvant chemotherapy is being the standard of care. This has been there for a number of decades, and we have, in fact, many randomized controlled trials that have proved this fact. Those randomized clinical trials has been formed what we call the LACE meta-analysis. Here we can see that there is consistent benefit when it comes to disease-free survival across different clinical trials that has been included in this meta-analysis. The same thing also, we have seen consistent benefit when it comes to overall survival across all these large randomized control trials. If you put these figures in numbers and you see what is the magnitude of benefit for chemotherapy in those patients, you can see that almost 5% there were an absolute benefit that patient can gain at 5 years if they get chemotherapy. So that's really an important step that we have for the last decades. Does all patient benefit from chemo? Definitely not. The most benefit that most of the time it's driven is mostly in the stage 2 and 3 are the one who will really benefit the most from adjuvant chemotherapy. When it comes to a stage 1, not all of them they do benefit. In fact, if you put stage 1A, in fact, they're not benefit. They are, in fact, we do harm if we give them chemotherapy. But while stage 1B, although this is based on the old staging system, is not the new staging system, the 1B is more kind of controversial, and that's why you need to select number of high-risk features in order to see whether they do benefit or not. Most of those high-risk features are the tumor size, plus others that you can also use in clinical practice. We know that those who have recurrence are mostly those with a tumor size, big T size, or the nodal involvement. If they have bigger tumor, if they have nodal involvement, are the one who really get relapse at some point. But this is one of the interesting retrospective analysis that probably published a year ago. It's showing that EGFR itself might be also a predictor of relapse. And that's in fact, despite the stage. If you look here, those are EGFR mutant, those are non-EGFR mutant. And you can see the rate of relapse is much higher for those who have EGFR mutant compared to the non-EGFR mutant. And this was seen across different staging, whether stage 1 or stage 2 or 3, somehow it's been trending. But this is kind of small retrospective analysis that probably need to be confirmed also in a larger, but it tells you that EGFR mutant, and when you look at the endpoint itself, the disease-free survival or the recurrence, I think it's really an important endpoint when you look at specifically for the EGFR mutant compared to other subtype. So the story for EGFR was a little bit difficult, and most of the earlier clinical trial that we have in the past, it have major issues. The first one was the Radiant trial, which is, though it's a phase 3 clinical trials, large patient has been included, probably 1,000, but it was unselected kind of patient population. And most of those who has been included are those with an EGFR positive by immunohistochemistry or FISH. So they're not an EGFR mutant, and that's one of them challenges that we have at that time. So, and this trial, those patients have been randomized to either erlotinib or placebo. All of them, they got chemo or no chemo, depending on what's clinical scenario. And when you look at the primary endpoint, it's really a negative trial. There's no really added benefit when you add erlotinib to those patients with unselected population. But when they did the subgroup analysis and they select those who have an EGFR mutant, we have seen a quite clear benefit. But this is a small unplanned analysis, subgroup analysis. It's not really enough to make any conclusion when it comes to this these decisions. The other trial is called the SELECT trial. It's a selected population, those with an EGFR mutant, but this is more kind of a small trial, phase 2 clinical trial, single arm, those patients were given an erlotinib, all of them, they get erlotinib for 2 years. And we have seen quite promising figures at 5 years that we are not used to see at that time. But this is small phase 2 is also not enough to make those any conclusion. The largest trial probably done in Asia, and that was adjuvant CTONG, and this is a phase 3 clinical trial. Those patients has been included at selected EGFR mutant, and they randomized to either gefitinib for a 2 years duration or chemotherapy. So the question whether TKI or chemotherapy, was initially was positive, and it was seen. And what we have seen here is this is the primary endpoint, which is a progression-free survival, disease-free survival. There was a clear benefit that was seen during the first 2 or 3 years, but this study was criticized at that time because the benefit that was seen probably at 2 or 3 years is really lost after discontinuation of gefitinib as part of the protocol, and by 3 years or 4 years that the curves has been overlapped, and whatever benefit was seen has disappeared. Last year at ASCO also they have shown updated overall survival, and there was no really clear benefit when it comes to overall survival. This is also the list of other clinical trials, including the one that we have addressed. Phase 2, phase 3. There's also another phase 3, which is the impact. It's almost similar design to the adjuvant trial, and it's. But when you look at all these trials, we have seen quite clear benefit when it comes to disease-free survival across all these trials. But this really did not really translate it in a kind of an overall survival benefit. The other point, all of these trials is really done on a first generation EGFR TKI, and that was the magnitude of benefit that was seen. One of the important facts, and probably why those trials did not really show survival benefit, these are the 2 large phase 3 clinical trials that was looked at gefitinib compared to chemotherapy in Asian population, and what we have seen is the most issue we have is the distant metastasis, and this is what's really impacting on the survival of those patients. But if you look at the pattern of relapse in those patients who has been treated with gefitinib or chemotherapy, you can see that the most issue we have is the CNS. The CNS relapse is quite high. In fact, it's higher with gefitinib compared to chemotherapy, and this was seen in both of those clinical trials. So we are losing patients because the CNS is really the important factor that really impacts their outcome, and that's why ADORA trial that was presented last year, it probably addressed this concern, which is the CNS relapse. This was one of the largest clinical trials that have looked at the role of adjuvant EGFR TKI in a patient who has been resected, EGFR mutant. They were randomized to either osimertinib for 3 years duration, or placebo. And all this patient or chemotherapy was being allowed to be included in any of those arms. The primary endpoint was disease-free survival, mostly in the stage 2 and 3, but also the stage 1 has been included. This study was unblinded early because of, as per IDM recommendation, because of the earlier signs of efficacy that was seen. The primary endpoint for this trial was disease-free survival, and we have seen that the benefit was quite clear. You can see the curve is quite separated much earlier, and continue to be separated even at a last follow-up. The benefit was the median is not yet reached. The hazard ratio is 0.17, which is something quite remarkable. The other important endpoint, which is not the primary, but it's disease-free survival in the CNS. We know this osimertinib is more kind of, or third generation are more kind of high potency when it comes to CNS activity. And we have seen the same trend when it comes to disease-free survival for the CNS. And here we have seen almost similar, even the hazard ratio. You look at the hazard ratio is 0.12 0.18. So there is clear benefit, either systematic disease free survival or even the CNS disease survival in favor of those patients who has been treated with osimertinib for 3 years. Not only the CNS, but when you look at the subgroup analysis across different subgroup, all of them, they do benefit. Different stage, different EGFR mutation subtype, even the chemotherapy, which is also one of the questions. What about those who have received chemo or no chemo? All of them, they really gain benefit in favor of osimertinib. The stage does matter, especially with chemotherapy, and we know that higher stage, they do get more benefit. And we can see here in this trial, stage 2 and 3, they gain the most benefit, but still we have seen also benefit in a stage 1B based on the old staging system, and the benefit is less, but it's real, and its hazard ratio also 0.5. There was almost kind of 18 or 15% absolute benefit when it comes to a 2-year disease-free survival. So all patients, they do benefit. Stage 2, 3, as well as stage 1B. Still, the data was not really mature enough to look for an overall survival, and this is just the preliminary one, and I think we are looking for more update. The hazard ratio is 0.4. It's probably trending toward benefit, but I think it's too early to make those conclusions. I think we have to wait for maturity, which is just 5%. So I'm sure we'll have more update in the coming future. When you look at the relapse, this is one of the also updated analysis that they have looked with ADORA. And when you look at the rate of relapse in those patients with who has been treated with osimertinib, is only 11%. While there was 46% for those patients who has been treated with placebo. So it's almost 5-fold the rate of relapse in patient who has not received osimertinib in those arms. So, but also the other important point is when you look at the pattern of relapse in those patients who has been on placebo arm, you can see that most of those relapse are distant rather than local, and vice versa when it comes to osimertinib. Although the rate of relapse is much lower, but it's less distant than local. So that means this drug is really working quite well when it comes to reducing the distant failure, which is one important predictor for probably the outcome. CNS is one of the important fact, and this is probably I have shown you earlier in the earlier trials with the first generation. CNS is one of the major issues we have, and when you look at this subgroup analysis or the site of disease recurrence when it come when you compare osimertinib versus placebo, you can see there's a significant reduction in the CNS relapse in patient who has been treated with osimertinib. While 10%, so it's almost 10-fold in increase in them in the rate of relapse or the CNS relapse if patient did not really receive osimertinib, and that's really an important fact that also has been addressed in this trial at last ESMO. We know the drug for a while, and we have been using this drug in metastatic setting for a number of years, and we know the side effect. It's quite tolerable. Even when you treat those patients for 3 years, most of those side effects are quite kind of grade 1 to 2, very minimal grade 3 toxicity that we can observe when it comes to osimertinib during that time frame. So the drug is quite tolerable. That's why probably new clinical trials have been addressed, and that's why it's new ADORA. Probably this has been earlier shown by Dr. Ahmed. It's really ongoing trial. It's really looking at this drug in a more earlier phases of the treatment, and that was it's not just single. There's 3-armed drug itself or the chemo combination, or the chemo. And I think this, we are still waiting for this clinical trial in order to assess the time frame that we can consider target therapy. And I think that's really an important step. Other oncogenic driven tumor also behave or going in the same pathway with an EGFR, and we are also going clinical trial looking at the role of adjuvant TKI in ALK positive. Here we have ongoing phase 3 clinical trial, the ALINA trial, which the trial that designed to look for the role of adjuvant alectinib in those patients with the stage 2 to 3, or at least stage 1B with high risk feature. And this trial randomized those patients to either alectinib for 2 years or chemotherapy alone. So it's different design than osimertinib. Here we have 2 years rather than 3 years. Here the comparative arm is chemo. So either chemo or TKI, and we're still awaiting for the result of this trial. We still have challenges when it comes to adjuvant or any treatment that we give in an earlier stage. One of the challenges is how we can choose the surrogate endpoint for an overall survival, because when you wait for an overall survival, it's really it's quite lengthy, and the importance fact is what is really the true surrogate endpoint for overall. So is it the disease-free survival that we use for adjuvant, or it's major pathological response or PCR that we are using in a neoadjuvant setting? And that's really important in order to have more earlier approval for the drug and to be used in a real situation. The other thing is which patient we can select for adjuvant therapy. Does the stage matter? Histology? What about circulating DNA? Does it really have an impact on the way we select patient for an adjuvant or no? We also in the era of combination therapy, and what's the role of TKI in general as a single or combination with chemo or with anti-angiogenic, or immunotherapy might be also another combination approach. Those drugs also is not really cheap, and one of the things that need to be addressed also the financial toxicity from those drugs, especially if it's given in a longer period of time. And that's one thing. The other thing, which is also one of the dilemma, for how long we should continue the adjuvant therapy. Is it 2 years, 3 years enough, less, more? I think that's also a question that need to be addressed in the future clinical trials. Finally, this is probably the take-home message. I think we have now new agent that we can use in the adjuvant. EGFR TKI osimertinib is really an important practice changing for those patients with the stage 2 to 3 as well as stage 1B. After complete resection, we have clear benefit when it comes to disease-free survival. That's regardless whether you use chemotherapy or not. Still, we are working on the pre-operative neoadjuvant setting, whether it's the way to go. And I think that's still at the time we speak is investigational. There are similar stories are happening in other oncogenic addictive tumors. Things are coming in the ALK, and also others are coming in the near future. With this, I think I reached the last slide I have. Thank you so much.
You're muted, Dr. Jamal. Are you saying something? Okay. So thank you for all the speaker. It was an excellent diversity between surgery, radiation, and also medical oncology. So I have a question for, and anyone from the audience here, they are welcome to ask any question. So my first question came from one of the audience virtual for Professor Khaled Alkattan, and he was asking about the predictor of successful lung surgery and what exactly you look for successful outcome on doing any lung cancer patient surgery.
Yeah, yes, thank you. Thank you. As I understand the question, you know, I think the key for what we call consider your surgery successful is that well planned. and it's not a single person decision, as probably me and others have emphasized, that it is a tumor board decision, very well studied pre-operatively, radiologically, in a multidisciplinary team. All the required investigation was done. So that will reduce what we call number one, exploration without resection, which is open and closed cases. Number two, resection without residual tumor with good safety margins. Number three is that proper oncological steps have been taken, like in-block resection and good lymph node dissection, whether it is lymphadenectomy or at least staging of each station. At the end, the outcome of the surgery will much be better than unplanned, undecided thing. So I think it's not just a surgical technique that a good surgeon would carry, but it's the setting and the sequence of events from decision to post-operative and discharge and need of post-operative care, as we listened, is the key for a successful surgery.
Thank you, Professor Ghatan. My second question for Dr. Henry. We've heard a lot about SBRT and how fancy this technique, and it seemed that it might be replace surgery in early lung cancer. So we understand that this is mostly nowadays for non-operable patients who are medically not fit. If the patient is operable and fit, and that's a patient choice to go for SBRT rather than surgery, what will be your response in the clinic?
So I'd still do encourage patients who are fit and operable to undergo surgery, as their overall treatment of choice and as the gold standard. I don't think we've yet proven that SBRT can truly replace surgery for those who are fit and operable. Some patients absolutely will not undergo surgery, and I'm willing to treat them with SBRT, but I do counsel them on the potential risks of foregoing surgery there. Some of these patients I keep a closer eye on, even with CAT scans afterwards, usually a little more frequent surveillance. I'm more likely to get a PET scan for anything that looks even a little bit suspicious, given that I do want to make sure the salvage lobectomy option is available for them if they do have a local recurrence. So, so it's something we do a fair amount, but not very often, because we do, we really do approach this with a multidisciplinary model and have the surgeons involved and us, and we really very strongly encourage those patients who are very fit to undergo surgery.
Thank you. So the third question for Dr. Ahmed Alleheibi, and you talked, Ahmed, about the neoadjuvant. So how you stratified your patient, or when you teach your fellows, which patient can go for chemorad as a neoadjuvant or chemotherapy, and now immunotherapy is on the way. How you choose the right patient for the right choice for the neoadjuvant?
I think this is an excellent question, Dr. Ashwag, and thank you for the question. So far, the neoadjuvant approach should be strictly prescribed or given as an option for patients who had a stage 3 disease, meaning a locally advanced disease, strictly. And it's exactly as what Professor Alkattan had mentioned in his talk, is that the main decision about that is the N2 status can be a main driving factor in that, in the fact that not all N2 diseases are the same. So a multidisciplinary approach should be taken in place when we talk about stage 3 disease. And if the decision by the team is to go for a neoadjuvant treatment, then you would have to look at the unique patient's characteristics, or whether or not they're going to be able to sustain the neoadjuvant chemotherapy alone versus neoadjuvant concurrent chemorad, keeping in mind that there is no definitive regimen that can be used in a neoadjuvant chemotherapy, and it's all extrapolation from metastatic setting. So that's when we talk about neoadjuvant chemo versus concurrent chemorad. When it comes to immunotherapy, I think it's going to be a very interesting era. the Checkmate 816 is a very interesting study. And I think just looking at the data preliminarily, it can convert or can convey a very promising results in the near future in terms of overall survival benefit, but we're going to have to await that. But that can be one approach with such significant MPR and complete pathological response. And more interestingly, is the Notoka study that I described earlier, which looked at quite various number of drivers mutations that can be targeted in that setting, and more notoriously is the Neoadjuvant. So far, there hasn't been a one unified answer for what is the optimal neoadjuvant systemic therapy. And in the near future, we'll have more abundant results and more substantial data to concrete on that.
Thank you, Ahmed. My last question here is for Abdullah. Abdullah, we know from TKI as an adjuvant, probably the data from osmogatinib is the most striking data, and probably most of the people with EGFR mutation, I think probably will be a candidate. If you're in a hospital situation that you don't have only first generation TKI and the patient is EGFR mutated for adjuvant, would you use first generation TKI or chemotherapy if you don't have osmogatinib?
Yeah, thank you so much, Dr. Shwag. I think when it's come to date for EGFR or first generation, it's been looked at and a number of clinical trials. There are some issues with those clinical trials, but it's really answer them. It's really proved that this drug worked, but it's mostly disease-free survival benefit, and there was no overall survival benefit. So when it comes to clinical practice, I wouldn't really use first generation. I don't think we have any supporting evidence that those drugs can cure patients. And this is what has been raised with one of the Asian trial, which is the CTONG. It's probably we have seen disease-free survival benefit that was seen over the first 2 years, but all these benefit has been disappeared with a longer follow-up. And one of the major issues we have with the first generation is the CNS relapse. And the CNS relapse is the one really then can impact on the outcome. And that's why probably you don't need just the EGFR TKI, you need the third generation TKI just to control the CNS disease, which is one of the important and the common rate of relapse that comes after surgery.
But if we have no options, we don't have the drug, would you use chemo?
Yeah, chemo, definitely. The chemo is an option, whether you are using first or third. I think the issue we have with the ADORA trial didn't really answer who really need the chemotherapy. And half of those patients has been received chemotherapy, the other half did not receive chemotherapy. Still, we are figuring out whether the chemotherapy is really important or not. I don't think this trial answer this. So definitely if patients are candidate for chemotherapy, they should get chemotherapy. And then you can consider EGFR TKI, the third generation, as an option afterwards.
Thank you. My co-chairman, Dr. Jamal, Salim, do you have any questions for the speaker?
Thank you, Dr. Ashwaq. I may have one very quick question for Dr. Park. Dr. Park has shared with us the data presented in ASCO 2021, showing good outcome with SBRT in early disease. And based on that, or maybe even before, a number of studies ongoing now comparing SBRT with surgery. So in these first 3 studies going now, how did they address the adjuvant treatment in the SBRT arm? One can assume they have included adjuvant treatment in the SBRT arms based on the adjuvant treatment after surgery and what we have learned over the past 5 years. Is that fair? In particular, if the SBRT arms come on top?
I missed part of what you were saying, I think, because of but I think your question was there any adjuvant therapy in the expanded STARS protocol, right? As they do after surgery. Was that your question?
Yeah, and what was it? And is it fair to give adjuvant chemotherapy that's based on surgery after SBRT, in particular if the SBRT arms become, come on top and change the practice?
Right. So I think I'm actually not certain about the percentage of patients who got adjuvant therapy after SBRT in that study. I'm looking forward to the manuscript as well to see what has happened for those patients. I'd say overall, our practice pattern here is to consider adjuvant chemotherapy for those patients with tumors larger than 4 centimeters who are receiving SBRT. But I believe that it's very challenging to a lot of these patients are not very fit for surgery, and it doesn't necessarily exclude them from getting adjuvant chemotherapy, but they're often not great candidates for that either. So I think we probably do less adjuvant therapy, at least less adjuvant chemotherapy after SBRT than we may do after surgery. There was a study out of here as well that has looked at those who have gotten adjuvant chemotherapy, and they did have improved regional and distant control compared to those who did not, which does make sense to a certain degree. So I think that's really the impetus of a lot of these immunotherapy studies, is to really not necessarily to increase the local control, but to improve the regional and distant control as well afterwards, that may be more tolerable than chemotherapy, to be able to give immunotherapy after SBRT. So we'll see what the answer shows over the years.
We have a question from Dr. Nafisa.
Thank you very much.
Come here, Nafisa.
Okay, thank you very much. I would like to thank the speaker and the moderator for their excellent input in this meeting. Thank you, Ashwag. My question is to Dr. Henry Park. This is like very practical question. Do you think immunotherapy added much toxicity to SBRT? Do you see more toxicity from this combination? Do you think certain patients should be excluded, or do we need to do certain tests before committing this patient to this combination, like doing pulmonary function test? And I have another question to Dr. Abdullah. Abdullah, do you think the addition of or introduction of EGFR, the TKI in adjuvant setting will change the roadmap in the metastatic setting, or are we going to introduce chemotherapy earlier, not like before? Thank you.
I think that's an excellent question regarding the potential toxicities of SBRT and immunotherapy. I think a lot of it's known more from the metastatic setting that those patients who received immunotherapy with SBRT, it seems to be a safe combination. We also know we have trials as well with chemotherapy, radiation therapy, and immunotherapy for locally advanced cancers as well. But of course, there's concern with pneumonitis risk, with immunotherapy and SBRT, especially for those who have poor PFTs. So right now, there's no real lower limit on that. I can tell you I'm somewhat hesitant for those who have very poor PFTs to enroll them on these studies, given that I think we don't know yet for sure, what the safety is for these type of patients. But the overall studies for patients with metastatic disease where we do SBRT, usually a lower dose though, but with immunotherapy seem to show safety in the synergy. With the combination of SBRT with immunotherapy at this point. But I think we have much to learn.
Thank you. Abdullah?
Yeah, thank you so much, Dr. Nafisa. I think when we are treating those patients for an adjuvant setting, that's mean our aim is to cure them. So I think that's the important gain that we get for those patients. But the way we deal at the time of progression or relapse, I think the same what we deal with in a metastatic setting. So those patients getting osmoretinib for 3 years. So if they progress during the 3 years, I think we'll do the same way where they in the advanced stage where they have to go with chemotherapy, because there is no other options that we have right now. So if they progress during the 3 years, I think the chemotherapy is the way to go. But if they relapse after discontinuation of osmoretinib, and I think that's where we can go back to osmoretinib, and because they are not really resistant or refractory, they are relapsing as what we do with other disease. So we still can use osmoretinib probably at the time of relapse if they are relapsed without the treatment. So.
Thank you. I think because of the time, I would like to thank you all. I'll try to thank my co-chair, Dr. Jamal Askari, Samah Alrehaily, and our speaker, Prof. Alkattan, Dr. Henry Park, and Ahmed Alleheibi, and Abdullah Twairgi. Thank you. It was very interesting and nice session, and probably we'll see you next year for the same thoracic meeting. So we'll go for a break, back at 4 o'clock for back-to-back satellite symposium.